Dr. Bancha will talk about the we'll talk about is rotator cuff repair technique important, planning beyond suture patterns.
Thank you, Ivan. So I'm talking about the cuff repair technique, planning beyond the suture patterns. Once you're talking about cuff healing, you need to think about the mechanical and biology, okay? So it's very important. The concept of mechanical factors is that when we repair the cuff, you should have less tension. Very important. You should have good coverage, maximum footprint coverage. And also the knot tying should not be too strangulate, okay? If you make too many knots, you make too many holes, you damage the rotator cuff. So before you start to repair, you make sure that you have good release of the rotator cuff. Make sure that the cuff is not too much tension because it will tear easily. So, and after the release, you should do a good mapping. So because the cuff repair, if you have good mapping, the tension will be lower. So I will try my best to make a good mapping. And then when you pair the suture, not one hole, one suture, like you have 12 sutures, do not make 12 holes. Because when you tie the knot, you will strangulate the tissue and finally it's torn. So for me, I try to make like one hole, not one suture. I will tell you what is my strategies. Okay? In the past, we make single row technique. Mason Allen is not bad. From the literature, it proved that Mason is good, have less type 2 tear, okay? Good tension. Okay? And next, after that, I do knot tying. This is a conventional knot tying, and we found that from the literature that a lot of type 2 tear because you strangulate the middle row. Okay, this article showed that 59% tear of the middle row. Okay, and mostly is at the musculotendinous junction, 72%. So I stopped doing this. Okay, and then I do this way, knotless suture bridge technique. Yeah. We found that it's good. Looking from outside is nice. But when you look into the joint, you can see some gap here underneath. That means you should have some knot. So we should be in the middle. So that's why we propose the hybrid technique. You do some knot tying, you do some knotless. Okay, this is my first literature. And I found that the suture distribution is not nice. So I changed from 3-3-3-3 to be 1-3-3-1. So one hole here, second hole 3 sutures, and 3 and 1. And then you make a knot tying like this, using the posterior pose. This one use anterior pose. And once you distribute, it will be nice and less strangulation. Okay? And after that, we found that if the patient have very big rotator cuff, okay, only 4 holes is not enough. Sometimes you need 6, like this patient have the massive supraspinatus and infraspinatus. We need more holes. So my strategy is 1-2-3, 3-1. Okay, like this. So you make the suture this way, you have less hole, but in one hole you have more than 1 sutures. Okay, when you tie the knot, use a proper pose, finally you will get this. Okay, and then you can distribute the suture nicely. Okay, this is for the massive cuff tear. So for me, if that small size, I use 1-3-3-1. The big size tear, I use 1-2-3, 3-1. Okay, this is 1, 2, and 3. And the hole between the gap should be wider. From the literature, we found that you should be more than 5 millimeters. Okay, I use it about 7 to 8 millimeters, but for the middle one, no knot tying, I use 5 millimeters. Okay, and you check intraarticular, it looks nice. Okay, no gap underneath. So for the partial tear, as we talked this morning, the bursal side we try to preserve the articular side because when you have 50% tear, we will not start from 0. Don't take down for my bursal side. I prefer to save my bursal side like this to make a good debridement, microfracture, and then you can use like suture bridge. Okay, this is very good biology because you preserve the articular side and you have internal spin because you have articular side as an internal spin. Like this patient, so he's active guy, he have a bursal side tear, I save his bursal side, he has good tissue quality. So for the articular side, as I told you, that can be from pasta in the young, it can be from degeneration or frozen shoulder. This patient, he's a doctor, she's very active, she's overhead athlete. So this is the way we do the pasta repair. Okay, we put two cannula in one in the joint, one above. Okay, then you can have like this. Okay, so the suture bridge in the lateral row, and particular side you use a transtendon repair. Okay, so this is the transtendon repair for the degenerative patient. This is 70 years old. He has bad tendons. You see that? This kind of patient we need to take down. Okay, take down the tendon and make a new tendon repair. Okay. So this is after the surgery. The patient have good healing and good function after surgery. Talking about biology. Biology is very important that you cannot control, like the age of the patient, comorbidities, tendon qualities, characteristic, healing environment like smoking, NSAIDs, and also biologic augmentation. Yeah. So I think this is a new things that we need to think about, because even you do your best, but the patient have bad tendon, the outcome will not good. So I try to preserve the vascular supply by leaving the middle, no knot tying. And this is a simple way to promote your healing by using the microfracture or crimson duvet. And from the literature proof that there's better outcome, better healing. PRP, there's many studies and they found that there's lower retaliate after you inject PRP, also the Bmax, right? This is a new things, yeah. So we need to follow. And now it's coming with the bioductive patch, right? And we found that the patient have better and better functions and also the healing after that. This patient have very bad tear, 70 years old. Okay, at that time we did not have regenerative, that was many years ago. So I discussed with him, he chose to do repair. So after the surgery, the patient have good healing, but anyway, the cuff healing is very thin because it's a poor tissue qualities. Yeah. So like this patient have massive revision surgery. So I do the release and perform the rotator cuff repair. So finally, he has a good healing after the surgery. Okay, this is tension-free repair. He has good healing, but anyways, sometime after the healing, you can see some white signal in the tendon. This patient had poor tissue, you see. This is my first regenerative, because at the beginning, I'm doubt that is that a good indication. I look at this patient, his tendon is white, is bad, but not big tear. So I did the surgery for her. Okay, I do the cuff repair. Her cuff is really bad. You see that? There's a lot of holes in the rotator cuff. So I cannot repair all the holes. So I take down the cuff and then repair her cuff back, put the regenerative in. Okay, so like that. This is my first regenerative. So after the surgery, okay, this is after the surgery. You see that the tendon healing is nice. This is just 3 months after the surgery. So after that, we found that there's indication. I talked with some friends outside. They said, what is the indication for regenerative? So if you look at the cup is bad, your cup is white, you have poor tissue qualities, like this patient, he has torn rotator cuff, you see? There's a lot of holes in the cup like that. So we do suture bridge and regenerative. Also this patient, bursal side tear, okay? So this is after surgery. I found that the patient recovery is faster. So take home message, when you're dealing with the rotator cuff tear, first you do your best for mechanical support, and don't forget the biology. Once you have poor tissue qualities, thinking about something that can augment your repair, okay? Like microfracture, PRP, Bmax, or bioactive patch, okay? Thank you so much, and this is our meeting and workshop in Thailand. So if you and this is my WhatsApp. If you want to be my friend, take this picture. Thank you.